Hello, everyone, and thank you so much for joining us today. On behalf of International Bipolar Foundation, I'd like to introduce our speaker, Dr. Joanne Nicholson. Dr. Nicholson is a clinical and research psychologist, professor of psychiatry at the Psychiatric Research Center of the Geisel School of Medicine at Dartmouth, and adjunct professor of psychiatry at the University of Massachusetts Medical School. Dr. Nicholson has established an active program of research on parents with mental illnesses and their families in partnership with People in Recovery. Her team is translating research findings into technology-based applications for parents with mental illness and evaluating interventions for families, including the pilot Family Options intervention. She is the lead author of Parenting Well When You're Depressed, and the recently released Creating Options for Family Recovery, a provider's guide to promoting parental mental health. Successful community living for a great many individuals living with mental illness involves family life and parenting. In the past, the focus has often been on who will take care of the adult living with mental illness, rather than on the notion that an adult living with mental illness may be, in fact, taking care of others. Dr. Nicholson will bring attention today to the needs of parents living with mental illness and their families, and will offer suggestions for creating opportunities for success in parenting and family life. By doing so, outcomes for both adults and children will be improved. While mental health services are traditionally organized to meet an individual's needs, recovery can be understood as a process through which the well-being, functioning, and quality of life of all family members is enhanced. She will discuss key concepts and processes of a family recovery model, along with strategies for advocating for and embracing a family-informed approach. Welcome, Dr. Nicholson.
Thank you so much, Debbie. And I want to start by thanking you for helping me navigate the technical challenges in being able to participate in this webinar this morning. And I'd like to thank the International Bipolar Foundation for inviting me to present this webinar. And I'd like to thank all of our attendees out there for signing on and participating this morning with me. I wanted to start by reminding everyone that the International Bipolar Foundation is doing some very important work and benefits from donations from all kinds of folks and organizations, and so we thank you for your continued support. I also want to start by thanking my own team, and we've been doing this work together, for a couple of decades now, and so this is just a partial list of the people over the years who have been involved in these projects and in this work, and it's been important to us to acknowledge that the vast majority of us on our team are family members or consumers ourselves of services and work in partnership. Our goal is to work in partnership with parents and families to help them achieve the goals they have and live the lives they would like to lead. Just by way of disclosure, I want to acknowledge that we have received support over the years from state, federal, and foundation sources, and also from AstraZeneca for as part of their community-based, consumer-oriented research priority, rather than anything about pharmaceuticals. No one on our team is a physician, and so we don't have anything to do with prescribing medications, and so I do want to make that disclosure. As you can see, and I hope you can see past the words on the PowerPoint slides to see some of the people and family members and families who have been involved in our work over time, because that was my goal in putting these slides together. Our work has been, of course, informed by a long-standing program of research, but most importantly to me, is the fact that the work for me emerged out of a set of personal experiences, and these may not be the kinds of experiences you would expect me to talk about this morning, but it's about me in a professional role that began, well, at the risk of acknowledging my age, probably 30 years ago now. But when I first started working as a psychologist, and as Debbie mentioned, I am a clinical rehab and a research psychologist. When I first began my work as a psychologist, I was fresh out of school. I was fresh out of clinical training. I was very smart at the time. You know how there are stages in your life when you're smarter and not so smart, or your kids think you're smarter or not so smart, but I was very smart when I finished graduate school, and one of my first jobs out of graduate school was as an evaluator for a group, a clinical unit in a psychiatry department who did evaluations for the courts regarding custody, visitation, and the termination of parental rights, actually. And so child welfare was involved as well as the court system. And one of the very first evaluations I did was with a woman who had been diagnosed with bipolar disorder, and she had a lengthy history of illness, unfortunately, and very thick, hospital records. And the evaluation, I spent weeks on the evaluation. I met with her probably 10 times. I administered every psychological test known to man at the time because, as I said, I was fresh out of graduate school and very smart about these things. And I ended up testifying in court as an expert witness in family court. The issue was whether she was capable of parenting her children or not. I probably spent a couple of hours on the witness stand, dazzling the judge with my psychological prowess, and talking a lot about this woman and all of the tests I had done and all of her results, which frankly were really not very healthy or good results. And I was made to really do a whole laundry list of the things that were wrong with her. I had evidence in the psychological tests about these things, but none of these tests, to be honest, are really related to parenting per se. But, this was the state of the science at the time. At the end of my testimony, the judge called a recess, and I was walking out of the courtroom, and the woman came up behind me, this mother, and she tapped me on the shoulder, and she said, "Joanne, don't you think you could just say one positive thing about me?" And I thought to myself, this is not a very strengths-based experience for this mother, or for me, frankly. And it really made me start to wonder about families in these situations. Of course, the gift of practicing in one place for a long time is that, what goes around comes around. And a couple of years later, I was supervising a psychiatry resident. And the way that residency training at the time worked was that psychiatrists did an adult rotation, an adult psychiatry rotation, and a child psychiatry rotation, and they were very distinct experiences. And so I was this young man's child, a clinical supervisor, and that was the focus of our work together. He came to me one day. He was completely agitated. He was pacing the room. He was totally anxious and upset and really unable to even sit still to talk with me. And I said, John, what is the problem? And he said, I can't talk about it. You're my child supervisor, and this is about an adult patient. And I said, well, maybe you could just tell me a little bit so that we could, sit still together here and talk about what we need to talk about. And he said, well, you're not going to understand this, but, in my inpatient rotation, I'm working with a woman in the state hospital, and she's on escape precautions. She keeps trying to break out of the state hospital. She has this whole delusional web. She thinks she has children. She thinks that people are trying to steal them from her. She thinks that they're out to get her, et cetera, et cetera. And of course, the more that he talked about this woman, the more I realized that it was my woman. It was the woman I had evaluated several years prior, who in fact did have children, who in fact could easily construe that they, the child welfare system or the legal system, were out to get her. They were trying to steal her kids. All of those things made sense when you thought about this woman as a mother, and particularly a mother with serious mental illness. But from the resident's perspective, who really had no training in thinking about people as family members or adult patients as parents, he hadn't even thought about that. And so we actually had quite a nice chat about this poor woman, but also it really drove home the point to me that adult services and child services are often not well integrated, and consequently we can miss opportunities to do better work when we don't think about the family perspective. Of course, if you wind the movie a few more years into the future, I was actually the director of a set of clinical support services for children who had been adopted. It was post-adoption clinical supports. And of course, who should the social worker bring into my assessment session but the children of this woman whom I had evaluated now a number of years prior and who had been on the inpatient unit. And here were her children who were not making it in their adoptive home. The adoptive parents were really unable to deal with them or manage their problems, many of which were frankly induced by the system. And so it seemed to me then that even the post-adoption services were not particularly family-focused or centered. Unfortunately, a few years after that, this mother went on to take her own life, and it really, for me, drove home the fact that our systems may be dysfunctional, possibly even more dysfunctional than our families, and it really prompted me to begin to take a whole family approach to the work that I did and the way that I was thinking about individuals in the context of their families. And so our personal experiences and professional experiences inform our work as well. The things that I'm going to talk about today, as Debbie mentioned, and we have a new book out called Creating Options for Family Recovery. It's available online at the Employment Options website as well as now at Amazon. And so a lot of the material that I'll be using today comes from and is available in that guide. A few talking points. Well, these are the talking points, the things that I want to talk about today. The importance of language, providing a rationale for family recovery, talking about some concepts and processes, and then making recommendations for us moving forwards. Language is powerful. Sometimes the simplest things are the most profound. The way that we talk about families, the way that we think about families, in our work, in our projects, families take many forms. Children can be living with birth parents, foster parents, step-parents, grandparents, adoptive families. These arrangements can be formal through the court system or informal through family arrangements. We work with families in whatever constellation they walk through the door. We believe that family is very much a self-defined, a family-defined business. Parents. Parents are parents for life, and that means that they are parents, and we consider them parents whether they're living with their children or not, whether they've had children removed from their care or not, whether their children are 45-year-old adults and living on their own. In our experience, people who haven't seen their children perhaps for years because of unfortunate family disruptions still define themselves as parents, and those are the most significant relationships in their lives. Our parents, we don't use the consumer language so much because so many of our parents and the parents we've interviewed and worked with in projects have not necessarily at the time been receiving or participating in mental health services. And frankly, the notion of consumer implies you have a choice or you can sort of comparison shop, like for refrigerators or televisions. And that's not always the case for our families either. So more often than not, we try to talk about people as parents because certainly to be a parent is a more positive label than to be a patient. And I would suggest to you that the folks we work with are much more likely to define themselves as parents rather than patients. Mental illness. And this is another set of words that's very powerful and means different things to different people, and people have opinions about these things. Of course, if you look in the literature, people talk about psychiatric diagnosis, mental health condition, psychiatric disability. There's a little bit of a political correctness thing that goes on with this. The folks that we work with, more often than not, have been labeled by professionals as having bipolar disorder or schizophrenia or major depression. From our perspective, we're interested in how parents think about and define themselves. We like to meet them wherever they're at, and our focus really is on well-being and functioning. And frankly, a diagnosis is a label that helps people communicate about symptoms and course of illness. But the fact of the matter is that one person diagnosed with bipolar disorder and another person diagnosed with bipolar disorder at the same point in time may look very differently, and over the course of their time, over the course of their lives, function better or worse, depending upon external circumstances as well as internal processes or biology. And so, we try to focus on meeting parents where they're at and on their well-being and functioning. It's also the case that among people living with mental health conditions who are parents, there's a huge range of better or worse functioning in the parenting role. I've had the experience actually of giving workshops, and in one workshop I remember a woman stood up during the Q&A period and said, my daughter is a parent and she's not diagnosed with mental illness, but she is a terrible parent. And so frankly, there's a range of parenting capacity among people who are, quote, well as well. Recovery, also another bit of language that has many meanings to many people. You could think about recovering your sofa, which implies something about covering up or hiding, and we are very aware of the stigma attached to mental illness and are really interested in promoting the agenda that it's not something to hide, but rather to live with, work with, manage. It's a process. Recover can mean something about finding something that is lost. And, when you're labeled with a mental health condition, there are often a lot of losses attached to that. So we want to respect the role of loss, but we're not suggesting that recovery is about finding something, or in fact, necessarily about curing or making things back to the way they used to be. From our perspective, recovery is a journey, not a destination. It's about healing. Not curing necessarily. It's about doing as well, being as well, feeling as well, functioning as well as possible, given your particular set of goals in the domain you choose, whether that's employment, school, training, or in our case, parenting and family life. The family recovery model that we embrace, therefore, is one that revolves around families and embraces the notion that families are the focus of mental health, that mental health is a family affair, and how well you're doing is affected by how your family members are doing, and how your family members are doing is affected by how well you're doing, that these relationships are multiply determined and interactive. A family is a system. And you can target one member of that system, but if you don't consider that person's place in the family or their role in the family, then the potential exists for you to miss the boat in your work with that person by not understanding what that person's really what their goals are, or what provides meaning for them in their lives. I said I would talk to you about the rationale for working with families, and particularly parents. And these are all, research-based rationale statements about the importance of working together with parents. And frankly, what I like to say to people is that if you are a parent, then you certainly know how important parenting is. And even if you're not a parent, you most likely had parents, and so you have some understanding at a very personal level about the impact of parenting and family life on how you are feeling about yourself and how you are doing in your own life. And so it seems to me that the rationale should be pretty clear and important to most people. Just a little bit of data for you. The majority of men and women in the United States diagnosed with mental illness during their lifetimes are parents. This is true across diagnostic categories, including what we consider some of our most severe illnesses, bipolar disorder, schizophrenia, and people with mental illness generally have their children at about the same time everyone else has their children, and they generally have about the same number of kids as everybody else has. So if you look at the average number of children, it's about 2. Young adults have received a lot of attention recently by our federal government in federal policy and funding, and are a very important target population. The fact of the matter is that young adults with serious mental illness are nearly twice as likely to be parents, well, 1.5 times as likely to be parents as those without a mental health diagnosis. And so, you know, young adulthood, the age of finding yourself, figuring out who you are, pursuing education, employment, training, finishing high school, going to college, most frequently are confounded or co-occur with reproduction, with parenting. And so a lot of the young parents we work with in this age group are wrestling with all of those life stage appropriate issues, as well as attempting to meet the needs of their children. Family, again, and I talked a little bit about this earlier. We think of families as systems. We take a pretty broad definition, and the research demonstrates that all family members are affected by mental illness in one family member, whether that's older parents who provide care to their adult children or grandchildren, whether that's siblings, and that all of these family members benefit from information and support. I love this quote. You know, I wish I could say that I wrote this quote. I wish I could say that this quote was from a famous scientist or psychologist, but in fact, this is a quote from a Boston Globe review of the television show Parenthood. But I think it really sums up the crux of the issue for us, that families can be the source of great joy and sorrow, and that parenthood is a challenge. And, you know, in the spirit of being a scientist myself, I developed this very fancy logic model. I'm being a little silly here, but it seems to me that the relationships are really clear, that family life can bring great joy and great happiness, and also can be the context for sad events and circumstances, and painful and traumatic events and circumstances. And it's the way that we move through these experiences that contributes to how well we're doing at any point in time, and of course the recovery process. It's our contention, therefore, that the family provides the context for recovery. And if you look, different people have different models of recovery, the important elements of recovery, and these are the important themes identified by this particular set of authors. And I wanted to give you some quotes from parents themselves that exemplify these key themes. I often feel like I'm channeling for parents with mental illness, and so a lot of the words I use, the quotes I use, are from the people who have participated in our projects and studies, and so I am grateful to them. Hope. This woman is quite articulate about the hope that her children provide for her, the hope for the future, the hope for a better life, a reason for moving forward, and and working on recovery. This parent talks about how taking care of her children really, well, she's got to get up, get her kids off to school, take care of her kids, making appointments, dealing with school personnel. It is the case. I don't know how many of you are parents, but I'm a parent, and I know that when my kids were little and they were sick, I would stay home from work and I would take them to the doctor and I would make sure that I stopped at the pharmacy and got the medication they needed. When I was sick, I would go to work. I would not go to the doctor. I would forget to pick up the medicine at the pharmacy. Often children give us a focus and organize, provide organization and things that keep us moving forward, things that we would do for them that we would often not necessarily do for ourselves, which is also an important message to those of us who are parents. Self-determination, figuring out what your goals are, learning what you need to learn, particularly to take care of your kids and to promote their resilience and have positive relationships with them. These are the things that promote recovery in parents. And of course, meaning and purpose. Again, this quote is very rich about the role of children in giving this woman's life meaning. And awareness and potentiality. This is really important. Kids in our day-to-day life often give us pause, often give us opportunity to reflect, often create for us or the awareness of patterns in our lives, in our day-to-day lives, that allow us to do things in a better way. This particular woman talks about her own life as a child, how she was parented, how often if people said, I never want to be like my mother or my own father, I'm going to do things differently. This particular woman had a history of trauma and really was committed to making sure that her children benefited from her experiences and that she did things better herself as a parent. The principles of a family recovery approach, and this magnifying glass is not meant to suggest that we need to spy on families, but rather that we need to shift the lens that we look through, that we the glasses that we wear when we're thinking about and looking at families, to be able to take the perspective of the family more readily. Some key concepts that we have developed in our work, both learned from other providers and other programs, and I've had great fortune to be able to visit programs and providers and parents and families around the world to explore what people do and why they do it and how they think it helps families. And so these concepts are gleaned from our own work in the U.S., but also from our colleagues and family members around the world. The challenge, and I've tried to set these up so that you'll see that the concepts are our answer to the challenge. The first challenge is that our parents grapple with the negative assumptions and the stigma that translate into beliefs and attitudes in the way they're treated even by professionals. And this woman is talking about the fact that her psychiatrist, in fact, didn't think that she should have a baby because of her mental illness and her medication. And so our response to that challenge was to suggest that providers really begin to think in a more family-centered way. And frankly, if they don't think in a family-centered way, they have the possibility of making mistakes, as this woman points out in terms of medication. People who are parents who have to get up early in the morning to get their kids off to school or fix breakfast are not going to take medication that makes them lethargic in the morning. And from the prescriber's point of view, from the provider's point of view, if you don't understand what that person's responsibilities are, what their family responsibilities are, and what their goals are for getting up in the morning and fixing breakfast and getting their kid on the school bus and being available to do homework after school. If you prescribe treatments, if you recommend hospitalizations without taking those family factors into account, you will undermine the success of your recommendations and treatment. Oh gosh, so many of our families deal with failure. They fear that they will fail because they have a mental health condition, and they're concerned themselves about their capacity to parent, or they believe the stigma and the negative assumptions that other people make about them. And of course, anyone who is a parent knows that there are ample opportunities to make mistakes in parenting. So the opportunities to feel like you're failing are vast for a parent living with a mental health condition. Our response to that is to make every effort to be strengths-based. And we work with so many parents who want to be the best parent they can be, who come to the task with so many skills and talents and interests and resources. And frankly, if they've been depressed for a while or really, really in that dark place for a while, it can be hard to remind yourself that there are things that you do well, that there are things that you appreciate about your kids, that you do have goals and want to do the best that you can do. And so a big piece of the work that we do is helping people remember what their strengths are and then mobilizing those strengths on behalf of their children and families. This mother talks about the kinds of things that all parents deal with. And that's a really important point, that the parents that we work with and partner with have all of the same issues that every parent has, regardless of diagnosis or health status. That family life is multitasking. And particularly if you're working outside the home or if you're pursuing training yourself, you've got to come home, deal with your kids, keep your household together, and for any parent, problems can really pile up. For a parent who has an illness, and that's whether that's a mental illness or whether it's a physical disability or a medical condition, those kinds of circumstances really benefit from active management. And active management really requires you to work with the parent, the mother, the father, to figure out what it is that they want to do, what their goals are, and how they can mobilize their resources to achieve their goals. So this mother said, look, I just want to be in charge of my house. I want to be cooking, cleaning, changing diapers. I do not want to go to the hospital. I do not want to, be off at treatment appointments that take me away from my household responsibilities. Juggling these tasks and activities and managing self-care, treatment plan, doing the things you need to do to take care of yourself as well is complicated business for anyone. But it starts with understanding what that person's particular goals are as a mother or a father. This woman says, I want to be there for my kids. I want to be available to my kids. I want to be emotionally available and physically available. And our response to this is to really be recovery and resilience focused with family members. Parents who can be supported in their recovery can promote resilience, the development of resilience in their children. Children do not necessarily have to get the mental illness, the diagnosis that their parents have. And research demonstrates that with supports, preventive supports, interventions, information, psychoeducation, that all these things can be changed in a positive way to support resilience in our children. For this mother, this was a father actually, as I think of it, how do you establish a loving relationship with your child when you're not with them very much? A lot of our parents fall victim to losing custody of or contact with their children. And, you know, I just want to be sure that you understand that I'm not here to say that all parents should be parenting their children. Frankly, whether you do or don't have a mental health condition, there's a wide range of parenting capacity, and there are some people who probably shouldn't be taking care of a plastic plant. But within the folks we work with, the vast majority of them are interested in and eager to maintain some kind of relationship with their child, whether they're caring for their child 24/7 or whether their child is living with a former partner or a grandparent or a foster parent. And so supporting them to sustain those relationships in whatever way is meaningful and relevant to them and their children and is not harmful or traumatizing to them and their children is really important. These separations and family disruptions can be really traumatizing for children and parents, and thinking about them thoughtfully in a planful way, providing parents with support when they visit with their children on a monthly basis or see them only at the holidays, helping parents prepare for those times, to think ahead about what their children might like to do and how to make that happen, to prevent those traumas rather than reinforce them is a big piece of what we do. We talk about key processes in our work, and while these may be processes that we talk with providers we train about, these are also, frankly, processes that can be embraced by any family or any family member, frankly. A focus on engagement and relationship building. Relationships are important. Attachment is important. Relationships are powerful and deserving of energy and support. Empowerment, supporting our parents and their family members in doing as well as they can on their own. Our goal is not to be lifelong partners with people, but to modulate that partnership so that parents are empowered to make their own decisions, achieve their own goals, mobilize their own resources, and their natural supports to live the kinds of lives they want to live. Being available and accessible as providers, we have warm lines and phone lines and work with people in home and work with people at school. Our goal is to be as available and as accessible as possible in the way that the parent defines. And so that means we spend a lot of time in the community and in people's homes, meeting with them and helping them think about what to do and how to do it, and advocating for parents and family members, again, in various community contexts, as well as with other providers and colleagues in professional roles, to make sure that our parents and families and family members are getting the attention and the respect and the services they need. So recommendations for moving forward. I think something that happens, especially when you think about families as systems and things being multiply determined, and what you do affects how your child is, and what your child does affects how you are, it can get pretty complicated. Thinking about, okay, what am I supposed to do to make this situation better for my family as a provider or as a parent or family member yourself? This old adage, and I don't think Hillary Clinton invented this adage, by the way. I think this has been ascribed to lots of different cultures and probably exists in lots of different cultural contexts. But the notion that it takes a village is really an important one in our work. And one of our goals, a thing we think a lot about, is, okay, so what does it take to create the village? What can we do to put a village in place for parents and families, many of whom are isolated by interpersonal style or by life circumstances. They may not have a car. They may not have access to transportation resources. How can you create the village, that promotes family life for these folks? So taking a multi-generational and developmental approach, supporting recovery in adults, supporting resilience in children. These are the kinds of things that the village needs to be supporting on behalf of our families. These recommendations, and all of these recommendations actually are research-based. And I chose not to really emphasize the research, but more to take advantage of this opportunity to chat with you about these things that are so important, we think, to parents and families. Promoting children's mental health. You know, families determine whether children get the kinds of help that they need, the supports that they need. Family involvement affects how well children do at school. It's important to promote children's mental health, to meet children where they're at. So school-based programs, we have colleagues who are developing school-based mental health promotion and prevention programs to help give kids the skills and the information they need to promote their resilience and well-being. Older youth, programs that have been shown to be successful target employment and education, mentoring, case managers who really work with older youth and young adults to help them achieve their goals. And frankly, in our programs and in others, these young adults are often parents and often require childcare so that they can participate in training, education, employment programs that support their goal achievement. And providing family-informed resources and supports to parents. You know, people say, providers say, and I have worked with oodles, thousands of providers, they say, well, I wasn't trained to do family therapy, or I wasn't trained to work with kids. I was trained to be an adult psychiatrist. And I would say to you that whether you're trained to be an adult psychiatrist or a child psychologist or, you know, whatever, that the people you work with aspire to be family members and care about their families and set goals that are related to their families. And so whether you're working in supported housing, supported employment, supported education, whether you're a psychiatrist working with an individual adult, if you do not know whether that adult is a parent or whether that adult wants to be a parent or whether that adult had children and they're living with a grandparent or whether the children of that adult are 45-year-old adults living on their own, if you don't know that about the, quote, patient you're working with, you're not working with that, quote, patient in a helpful way. And so our perspective is that you don't need to be doing family therapy. You don't need to be doing, you know, family psychoeducation. If you're working with an individual child or adult and you're not taking the family context into consideration, well, then you're doing both of you a disservice. Fulfilling valued social roles is the key element in the recovery model. And in this report from the National Council on Disability, they focused primarily on work, school, and being a family member. They did not target being a parent, and I added that to this list because I think it's often the thing that's missing. I think our federal government has spent a lot of money on housing, employment, education, and all those things are really important things. I mean, work, successful work is very healing. Succeeding, achieving at school is very healing. All those things really matter, but parenting and family life matter as well. And so I want to drive home the point that family roles are valued social roles, that we need to question our assumptions, that we need to help families navigate our systems, that we need to build bridges among services and supports, and also among families, because families can help each other and provide peer support in situations where professional support may be unnecessary or unwarranted or irrelevant, frankly. So partnering with families to achieve the goals they set, that's what matters to us. So how do you start? You know, people ask me this question all the time too. Do we need fancy programs? Do we need, you know, what can I do? I'm just a person in my community, in my neighborhood, and I know there's a mom down the street who's having trouble, or I'm a school teacher and I see that kids are in difficult situations. One could get overwhelmed with the prospect of trying to make change happen. But, you know, as I said in the beginning, I sort of always fall back on personal circumstances and personal experiences, and I would like to suggest a very simple thing to you, and that is that the way to start making progress on this agenda is to make it personal and to begin by identifying strengths. And I have a couple of cartoons in here to remind me to make these points, because I think that you know, lots of times parents get blamed for things. I love this chicken crossing the road cartoon. I crossed the road because my parents made me do it. I suspect that there are a lot of people who have sat on psychiatrist couches talking about all of the ways in which their parents disappointed them or hurt them or you know, were not what they hoped or expected them to be. And I would like to suggest to you that we need to move past this parent blaming place. And I'll tell you a story to end this webinar today, my presentation. That's again a personal story, but apologies, because because I had this experience relating to my own mother, and this is a cartoon obviously from the New Yorker, in my house, and you've probably never been to my house, but in my house, the laundry is in the back room, and I fold the laundry on my bed, on our bed. And so I don't know where you fold laundry, but that's where I fold laundry. And one day I was carrying a load of laundry in my arms, walking from the laundry room to the bedroom, and I went past the bathroom, and I had opportunity to glance over my shoulder into the mirror, the bathroom mirror, and I stopped dead in my tracks because I looked exactly like my mother, exactly like my mother. And I actually stopped, you know, and went into the bathroom, and I set my load of laundry on the vanity, and I sort of looked at myself in the mirror, and I said, holy cow, I am turning into my mother. Now, that could be, for me, a very slippery slope. I mean, my mother was ill for many years. She had a lot of physical health, a lot of medical conditions. She was profoundly depressed for much of my life, and for me to think that I was turning into my mother could have been a slippery slope into a very black hole. And it was really important to me in that moment, as I was looking in the mirror and seeing my mother, to stop and think about all the positive things that she had done for me in my life. And frankly, she taught me my most important life skills. She taught me how to paint and spackle and wallpaper. She taught me how to sew so that when I grew up and was a mom, I could make my daughter's Halloween costume. She taught me how to cook. She taught me how to balance the checkbook. She taught me the importance of learning how to type, which is frankly one of our basic life skills these days with computers. She really gave me a lot, and frankly was a role model of really struggling in her own recovery to make things better for herself and her family. And so I would say to you that when you look in the mirror, or if you're a provider working with a parent or a child, when that person looks in the mirror, if that person, well, I can guarantee that person will see their parent somewhere in that mirror, whether they live with their parent, whether they haven't seen their parent in 80 years, it's inevitable for all of us. And when you look in that mirror, if you cannot identify at least one or two positive things, then you're in real trouble. And so I would suggest to you that the way to start, the way to make it personal, is by beginning to identify strengths in yourself and strengths in the people around you, whether that's your family members at home, whether that's your neighbors and their barking dog in the backyard, whether that's the people you work with in a professional capacity. Because I believe the way to change the agenda, the way to move forward in the family recovery agenda, is to simply begin by identifying strengths. I thank you for your time today. I really appreciate the opportunity to participate in this webinar, and I think we have a couple of minutes for questions, which I'll turn over to Debbie.
Excellent. Thank you so much, Joanne, for your presentation and your insight. We do have a few questions, so let me start with a comment. Thank you so much for the presentation. This attendee is addressing you. What, if anything, do you recommend we do to promote more responsive systems to parent mental illness, particularly with regard to prenatal and postpartum mental health challenges?
Well, I think we need to begin by acknowledging, by believing that people with mental health conditions may well want to become pregnant, may well have perinatal challenges, may benefit from some consultation, particularly around the use of medications. Lots of people think that when they get pregnant, they should stop all their medications, and that's not necessarily the case. So I think beginning to question some of our own assumptions about what pregnancy and that transition to parenting are about, advocating with providers to have them question their assumptions, and to really embrace the notion that people with mental health conditions are having children, want to have children, and want to create the best environment for their children, whether that's a prenatal environment or, in the transition to parenting.
Great, thank you. The next question, your thoughts on early intervention. Can it really truly prevent or reverse a severe mental illness course?
Oh, sure. I think that decades of research would suggest that. And I mean, even, well, certainly early intervention services are key to helping people have the best possible outcomes they can have. Now, a small percentage of our disorders have a biological basis, but we know that things like life circumstances, stress, negative interpersonal relationships, all these things affect the ways in which those genetic predispositions emerge. And so early intervention, school-age intervention, all those things for our kids are really, really important.
Great, thank you for your answer. It looks like we are finished with the questions. Certainly sometimes I know that, oh, whoops, sorry, another one popped up. Let's get to that. Okay, question about it being, your webinar being available online. And yes, all of our webinars are recorded, and this will be archived on our website. And if anyone has a particular question that comes to mind after the fact, please don't hesitate to email me at dbrown@ibpf.org, and I'd be happy to forward that to Joanne. So thank you again, Dr. Nicholson, for joining us today, and we hope everyone has a wonderful day. and we'll see you at the next webinar.
Thank you.